years old, trauma from sports. As usual, football is the sport we see the most. And this patient has had torsion. We can see leaking. We can see clinical instability. These are the x-rays of the patient. This is a patient with trauma with potential ACL lesion. And we can see that this patient has open physis. So my first question is, how do you specifically treat these ruptures in young patients? So does anybody have an opinion about this? Gustavo, what's your opinion? Rafa showed us some simple x-rays to make sure that there are no lesions or avulsion of the tibial spine, and which we've basically discarded. How did you study this particular age? Can you tell us about this?
So for me, if the young patients that have the ACL injury, so first thing you need to see any avulsion, right? Like tibial avulsion or avulsion fracture that we need to fix, or you have bucket handles of the meniscus that we need to get in. Otherwise, if there's only the isolate ACL injury, I will try to do conservative treatment. I try not to operate unless the patient is more than 14, 15 years, the physis is going to close. So in that situation, we will do the surgery, right? Otherwise, if the patient have no concomitant injury, isolate ACL in the young, I try to conserve. But anyway, I need to discuss with the patient, also the family, right? That we need to wait a while, okay? Unless that anything that we need to get in and fix. That's my idea.
Well, we indeed, my management is pretty much similar as what Bancha has mentioned, right? Unless we are forced to do something, like for example, if they have a bucket handle tear or a avulsion fracture, that you need to do something. Otherwise, if it is very young, like for example, I'm not sure about the age because I listened to the interpretations, the translation, right? But maybe this is maybe a 9 or 10 years old or so, right? So mostly we will still for non-operative treatment, right? Of course, there are options, right? Indeed, just several days ago, myself and Bancha, we were in another conference and we discussed exactly about this. And then the options on like the fascial-sparing ACL reconstructions, or even in the old days, those extraarticular procedures are still okay, but they are not anatomical, and also, you know, they still have their own risks, right? So essentially, mostly is non-operative treatment from my side. Thank you.
Muchas gracias, Prof.Dr.Bancha. Y Gustavo, con respecto a los estudios, ¿qué otro estudio pedirías en este paciente?
Thank you, Professor Bancha. Gustavo, would you do any studies? Yes, the X-ray allows us to look at physis, and with the MRI, we can see that it's basically all scarred. So in this case, the X-ray is fundamental. We tend to do a bit more intervention in our case. We prefer to do surgery to avoid chondral and meniscus lesions, which lead to arthrosis, and it depends as well on the skeleton of the patient and their sexual development, and we obviously take into consideration the graft to be used based on this. Okay, Arturo, any other studies apart from X-rays and MRIs? I think that in this particular group from 13 to 14 years old, it's not really necessary to make any other X-rays to look at the bone age. Maybe in smaller children, as Gustavo said, we used Hannah and hand X-rays to also make decisions. But in this particular case, at least on average, this is the most common, this is commonly treated in our hospital with MRIs and X-rays that will allow us to make decisions. Okay, Rafael, the discussion here, the ages 13 to 14. These children have very little adherence to conservative treatment, which implies changes in sports activities, and so they can suffer associated issues. They show certain changes when there's certain levels of aggression. This is the MRI with the ACL and an associated lesion. We have a patient here with an unstable knee, which is hyper lax, so there's quite a high degree of movement, and he has a rupture on the meniscus that is unstable, it's internal and unstable, that basically conditions the conduct that we should follow. In terms of the focus, these patients are in an age of growth, and so what we do is perform a study with the tanner, as you all do. We look at the bone marrow because we want to give the family a degree of tranquility. Obviously, such as this in this condition, the meniscus, this is involved in the meniscus. And we also look at the family history. In this particular case, this is a 13-year-old patient with quite a tall father and brothers. So with that, there is certain considerate potential for growth in this patient. So the second question is that in this condition, when they have an unstable knee with meniscal lesion, obviously we're going to try to suture. What do they propose? What do you propose for the patient as surgery? Dr. Bancha and Dr. Patrick were telling us about their opinion, just like Gustavo.
Yeah.
I wonder whether Arturo would like to maybe provide his opinion as well. I just want to clarify here for the audience that the most important thing here is to look at the potential for growth in the patient. So the bone age isn't as important. What is important here is their growth potential. So how much more will this patient grow? And based on that, then obviously we have to find the right technical or technique for surgery. But this is a meniscal lesion that we need to resolve as well. Arturo? Yes, in this particular patient, how tall are they? The bone age is 13.2 and the height is 162, I believe.
Mm-hmm.
So 20 centimeters to grow, perhaps. Well, we don't know.
So I think his bone age is more than 13 and he's quite tall now. And he also concomitant meniscus injury. From my idea, I think in this case, we can get in, right? But the way to do the ACL reconstruction in this patient, you need to make it more special. The tibial tunnel, you need to make it vertical. I prefer to set the angle to be 65. And my tunnel will be in the center, okay? When you go center, even there's a slight LS, no problem, because it's in the center, okay? And I use the soft tissue graft. For the tibial side, I cannot avoid the physis injury. We go through the physis, okay? But for the femoral side, I prefer to use outside in, physical sparing, okay? And I use button and button. I will not use screw for this kind of patient. So we do all inside ACL reconstruction. Tibial side, make it more vertical. Make the tunnel in the center. For the femoral side, I do outside in, using button and button. That's my idea.
For me, it's a little bit different, right?
Okay,
very
Patrick?
much similar to just mentioned by Bancha. First of all, I think myself and Bancha didn't know that this is a case of 13 years old because we just listened to the translation that was not mentioned, right? So we think that that was a case of like 9 or 10 years old, right? But for 13 years old or 14, right? I think most of our cases, I will still go ahead for ACL reconstruction, given that this is a case of with meniscus tear, right? As mentioned, soft tissue graft, central tunnel over the tibia. But even for the femur side, I won't choose, I didn't perform physical sparing, right? I still use a conventional way, but just use small tissue, so soft tissue graft, and you try to put it more like, near the top of the notch, but not, right? For example, 1 o'clock or 11 o'clock region. So as to minimize the possible damage. But having said that, indeed, there are lots of studies showing that with a one shot of like femur tunnel drilling, it only occupies about 3-4% of the area of the physis. So that will not cause any significant damage of the physis if it is like a tanner-free or above cases. So that's the way I'm doing, right?
Rafa, ¿quieres continuar con el caso?
Sí. Entonces las horas terapéuticas.
Rafa, would you like to continue with the case? Yes, as we said, the treatment would be conservative. because sometimes there is a lack of adherence among these children, but it is a meniscal solution via surgery. These are the different ways of treating it. So distant from the physis or the Anderson technique, which I really like, which is a piezoe and transtibial. As for the graft, normally we have we flex it. We shouldn't leave anything near the physis, and so we have bone. Obviously, in cases of bone and cartilage, they use this, and the type, it should not be transfissure. This is the reconstruction. The tunnels are more vertical. This is an important point to take into account for rotation. It should be distant from the physis. This is a slightly different case with growth. And continuing with this case, the patient then has another traumatic event, obviously in football, as usual. But now this patient is 17. We can see Lackman as a clinical study of instability. He's now 17, and there was a plasty rupture. How is this faced at 17? I'd like to go back because there's an important issue here. A while ago, you were talking about conservative treatment for children, but maybe in Asia it might be feasible, but here in Latin America it's very tricky, at least in the population that we see. Because in Mexico and in the rest of Latin America, children dream about being football players, so it's basically impossible to stop them. And the other issue is that they don't have special braces or functional braces for children here. So conservative treatment in our medium is quite complex. And I think having a meniscal lesion, I think there's no doubt that the treatment should be surgical. Okay, Gustavo?
I agree.
Yes, I agree too. I think keeping a child still is difficult. Obviously, we need to stabilize the knee and save the meniscus. And give them enough time for the graft to scar so that they can bear weight again. With the second event shown to us by Rafael, if we look at the X-ray, it's a graft with a transtibial technique, surely. As we can see on the femur, there's a transfix at the top of the femur. We need to review that. We would have to do a graft, do that in 2 different moments. Obviously, graft these defects. And when they're 17, you can do an adult operation with a technique through the medial portal with bone blocks in the graft and a better positioned graft that is more anatomical. And you'd probably have to do something additional in the periphery. Patrick?
Sorry, well, I hope I don't miss the information because I listened to the translation. So this is a 17 years old with an ACL graft rupture, right? Am I right? Right. So how about the meniscus, right?
Yes.
The meniscus is okay?
Yes, so this is the MRI for the patient, and it's a rupture of the plasty that was already done, of the reconstruction that was done before. So they're a candidate for revision surgery. It's the same patient that's now 17, and they have a new trauma event. This is the MRI. We can see the tunnel that's quite vertical. Some issues with rotation. We'd need to revise that as well. So the question is, what kind of graft would you use? How would you do the revision? Or how do you analyze the tunnels?
Well, first of all, looking at the MRI and the previous X-ray, it seems that, well, for me, the femur tunnel is a little bit vertical. It's most like a 12.5 to 1 o'clock, right? If you look at the X-ray. So in revision, I'm not sure, but I will look at it arthroscopically. In revision, sometimes you may just forget about the old tunnel. You can essentially drill a new tunnels, right, on the femur side. On the tibial side, it seems to me okay, right? So you can simply revise it. But I will also look at the meniscus and see see if the meniscus, especially the posterior horn, is okay or not for both the medial and the lateral side. If there is any doubt, I will proceed for, apart from revision surgery, you can use a BBB graft, okay? The only concern is a graft tunnel mismatch. To me, it seems to be okay for the tibial tunnel, not too short, right? And then I may add on extra-articular tenodesis or ALL reconstruction to reinforce that if it is a case of like incompetent posterior horn of the meniscus plus evolution ACL, right? Just to play safe. Yeah, that's my way. How about Bancha?
I agree, Patrick. So first of all, you need to find the cause of failure. Number one, this patient have vertical femoral tunnel, so it cannot prevent rotational instability. Number two, always looking for lateral meniscus root. This is very common. Sometimes you miss the lateral meniscus root. If you do revision, it fail again because the lateral meniscus root provide rotational stability. And also the medial side looking for the lamb lesion, right? And also this patient, the slope is not bad. I think less than not too much for the slope. Okay. So the last thing is looking for extra-articular, the lateral side. Is there any lateral side injury like LL or posterolateral corner injury? Okay. So looking for everything, right? Find the cause of failure because before the decision making. Okay. Same like Patrick. So this one, if I revise, I prefer to use big size graft like the quadriceps graft. Okay, make it more not too high. Put the graft lower and address all the meniscus pathology. And if the patient have severe pivot shift, I prefer to do the modified lamella for the lateral side. Okay, so that's my idea.
Rafa.
Perfecto. Una pregunta para cerrar esta
Perfect. Just a quick question to close the first part. Very shortly, what's the indication for surgery?
Básicamente sería que veamos los túneles ensanchados.
I think we would basically have to widen the image of the tunnel, or because the tunnel could be in the way for the new tunnel. In this particular case, I don't think it has widened. I think the cause of the failure was that the femoral tunnel was not anatomic. So in this particular case, I think you can perform a technique in one surgery with a new anatomical femoral tunnel using the same tibia tunnel. I would use bone, tendon, bone. Something that I see here, and you will tell me, Rafa, I think the patella tendon is very long. So you might have to do a modification technique to be able to use bone, tendon, bone, so that there's not a mismatch there. Yes, perfect. Anyone else? Yes, Rafa, I think I agree with the words of Arturo and Dr. Young's comments. I think the femoral tunnel can be omitted and you can have a new, more anatomical tunnel. The issue would be with the tibia. We'd have to do a tomography to look at the width of that tunnel. Apparently it hasn't widened, but if you have any doubts, do two revisions, but I think we could probably treat them with one. What kind of graft would I use? Quadricipital bone block tendon with the block for the femur, and that collagen in that tissue would be left for the tibia. Go ahead, Rodrigo. Yes, there's a lesson here. If we were to return back in time, wouldn't it have been better to perform a more anatomical extrafisciary technique with an extra-articular type Leman technique? Yes, we were talking about these modifications that we would do now, because with the evolution of this case, I mean, it was a long time ago, but we used to do all kinds of things in children before, which is how we were told to do things like vertical tunnels, as we can see in this particular case with rotation instability. But these extra-articular techniques weren't so strong as they were before, but I guess because it's for children, it's debatable. Okay, let's continue because we don't have much time. We've got the tunnel here. It hasn't stretched. So basically we did one-time surgery. We used graft, bone, tendon, bone graft. As we were saying before, in the tendon, we basically did a study to look at the size and the length of the tendons of the bone, tendon, bone, because it may be left outside. And this is basically the evolution after 4 months, so that the evolution was good. And now the patient is 19 years old, still playing football, and there is a third event. There is hemorrhaging and pivot, and the pivot is quite significant. So at the age of 19, there's a third revision. How would you face that? What would you do? What kind of study, and what would you propose as treatment for this patient? Patrick?
Do you have a lateral X-ray? I just want to double check the posterior slope, right? Of the tibia, right? But if you do not, right, it's okay, right? Well, of course, I think the principle is this one to me is not very bad. The posterior slope.
Yeah,
right?
I agree.
I think it's okay.
It's
right?
not bad. Right.
Yeah. So this a bit unfortunate that this guy re-rupture and re-rupture again, right? So at this juncture, I think this is a high-risk patient, right? So with a 3 times rupture of the graft and so on, while you have already revised it, right? So you may like to revise it and adding an extraarticular procedure, either like modified limit or AL reconstructions, right?
Okay, so I agree with Patrick. If you check everything, no meniscus problem, right? This patient, you did not mention about the meniscus root, meniscus ramification, meniscus root of the lateral side, nothing. And also the pivot is 3+, right, for these patients. Any ligamentous laxities also?
No tiene. No tiene lesión de.
No lesions in the posterolateral part or the meniscus, but he does have a significant pivot with instability in all points, as you can see here in the assessment. So clearly it's an unstable knee. Can you ask about the axis? Is there varus? It's a normal axis, no dysmetry.
Yeah.
But in this case, the focus is on instability.
Right.
Do you have an X-ray, Rafa? Or a tomography? Well, in the MRI, as you can see, the tunnels are more or less maintained with an adequate diameter. But when we see that the diameter is not adequate, we add a tomography and there is a normal axis. Okay, with regards to the tunnels, Gustavo, in terms of the millimeters, what kind of millimeters or percentages do you have when you're thinking about tunnels? Do you have any parameters that you take into account when you decide to have 2 surgeries instead of 1? Maybe 12 millimeters is the limit. Some studies say up to 14, but I think any more than that can lead to complications. So you would have to do a CT and really try to measure the sizes of the tunnels of stylitis and to see if if they are wider, then we would do that in 2 moments. Okay, what about the graft? What do you think, Gustavo? Which one would you use in this patient? Okay, well, I would insist on the quadriceps. It's an excellent graft. It has a large amount of collagen. It's easy to harvest. It's autologous tissue, and it takes more and more room in our practice today. So quadriceps. Okay, so is there a bone? If there's a bone in this case, would you use quadriceps? Yes, I've done lots of revisions with patients where they've taken HTH from the same bone, or BTB in English, and I wouldn't touch the contralateral knee.
But
okay,
you
Arturo,
check the quadriceps and the patellar tendon in the same knee. The patella is very weak. It can be broken, right? I prefer to use opposite knee, the quadriceps, because you already harvest the lower pole patella. And this time you harvest the upper pole patella. So it's too risky for me, I think. I use opposite knee, quadriceps. Yeah.
Yo también haría lo mismo. A mí me daría miedo tomar.
Yes, I would do the same. I would be wary of taking the quadriceps with a bone tablet, and I would take the contralateral one. In this case, if you go back to the X-ray, you can see that the femoral screw is divergent, so I don't think there are any issues. with the same femoral tunnel if you withdraw that metallic screw. And I would add something on the lateral part. Maybe we should have, or be very careful when we do the drilling to do Lemaire or something, because there are quite a few tunnels and there's a transfix, the metallic transfix as well. So maybe we'd have to withdraw that. I just want to go over something, Rodrigo. We frequently work on the quadriceps. We don't need it to be 20 or 30. I think a 20 is enough. So we need to respectfully stop being scared of taking the quadriceps. It's an excellent alternative. Our patients aren't usually that tall, so you could take a tall patient like this one without the bone block, but if not, it's taken with the bone block. And we have a very interesting experience that we're going to be showing you as well. Okay, perfect, Rafa. So you would you all do it anterolateral? Yes. So plasty or reconstruction? I would do tenodesis, Lemaire. I don't think reconstructing the bone capsule would be done. I think tenodesis, it's more than a 40-year technique, and that would provide a good result. Okay, does anybody want to provide any other opinions? Okay, in this case, a reconstruction was done. We used allograft. So there was a debate because of their age. We had an anterolateral plasty at the same time. So the patient is 19. And that's basically it.
What is that implant for the femoral side? It's
un implante que se usó acá.
It's an implant that was used during internal decodification. So it's basically, yes, exactly. It's an internal fixation.
We have not seen this before, right? This kind of implant.
Yeah.
No creo.
Look interesting.
Yes, I believe you. It was in the US and Chile, where developments were a bit slow, and it's not used anymore. It's probably the easiest way of fixing the femur.
Yeah.
And Sebastian Ordura is saying that for extra-articular, you should use, well, basically avoid conflict. Thank you, Sebastian, for your comment.
Well, I've just well, first of all, I haven't seen this kind of implant. I mean, for the femur, right? For the ACL, but for the suture anchor, is that for the limit, right? Or the modified limit, right? Whatever it is, right? Is it the extraarticular tenodesis?
Sí.
That you did, right? And I'm not sure, but looking at the position of the suture anchor, well, you know, suppose the ALL is a little bit proximal and posterior to the usual lateral epicondyle. So to me, it's slightly I would say distal and anterior. That's just my impression on that, right?
Yeah, I agree, because we always put it behind the lateral epicondyle, right? A bit higher than this. Right.
But maybe X-ray is not very accurate, right? So the intraoperative feeling is most important, I was saying.
Yeah.
Good. So shall we move on to the next case?
So it's good, right? This patient, finally, he's good.
Yeah, good.
Perfect.
El implante que ustedes vieron, que
the implant that you saw, which is the fixation, is called Cayenne. I'm not sure if you have this implant in your country.
No.
It's for the plasty. It was used for some time. It was called Cayenne.
Yeah.
We had that in Colombia for a while, but we don't have that anymore. Thank you, Rafael, for showing us your case. You gave us many teachings. Would Patrick like to share the case on the screen? Any comments from the panel?
Share my case. Right. Thank you very much. Right. So.
Creo que nos deja enseñanza este caso que como lo decía Rafa al principio,
I think there are some cases learned from this case, as Rafa was saying.
seguramente en la
There is extra-articular augmentation in the primary surgery that probably wasn't done at the time. Today, I think none of us would do anything isolated in this patient. So I think that's a relevant comment for these kinds of patients. Yes, completely agreed. Patrick?
Okay, now can I share my case? Can you see my screen?
Sí, la
Not
vemos
yet.
bien.
Perfecto.
Yes, yes. Perfect. Okay.
Yes.
So
It's coming. Yeah.
my case is very much similar, but a little bit different, right? So let me show you. Okay. So let's look at the history. This is a rugby player. At that time, at the first incident of injury, he was only about 18 years old, right? So he suffered from left knee ACL injury. And then at that time, he was in Japan and with operation done, which was a double bundle ACL reconstruction using hamstring graft, the gracilis and semitendinosus, right? He went back to sport about 10 months later. Unfortunately, he re-injured again, resulted in a graft rupture of the ACL, right? Now that was the X-ray, right? Well, I would say that looking at this X-ray, it seems to be okay, right? It's a conventional double bundle ACL with the AM and the PL bundle fixation with endo button. I think the fixation over the tibia is so like those biodegradable screws, right? Interference screw. Well, so at that time, after rupturing of the graft, the Latman is grade 2, anterior jaw is grade 2, pivotal is grade 2. MRI showed that is a graft complete tear with mild meniscus tear over the medial side and mild degeneration over the medial side. But the problem is that the CT showed a big tibial tunnel, right? Now, this is only the CT, right? So the tibial tunnel is like this, right? It's 14 point something, right? So, ladies and gentlemen, right? Revision, right? Suppose that this is an 18 years old boy, very good in, keen in rugby, right? He want to resume rugby. So revision surgery, what are the options, right? Bancha, you go first.
Yeah.
And
You check everything. The meniscus is fine, right? But Patrick,
yeah, just the medial meniscus is a bit like a tear, small tear, right? And probably that can be fixed, right? Yeah.
Yeah, I always looking for meniscus medial side, especially the ram lesion, and the lateral side looking for any lateral root. If there's no meniscus, then I'm looking for the bone. I'm looking for the slope of the tibia. Okay, is there any abnormalities of the bone? And
Really
also
good.
the axis of the knee.
Yeah.
Axis is good, right?
There was a bit of problem on the slope, but that was not being detected in first. But the major problem at that time by the surgeon was a big tibial tunnel, which was merged between the AM and the PL tunnel. Okay, maybe I can show you a little bit, right? So I can show you a little bit the intraoperative pictures, right? This is the AM, the femur side. Can you see that? I'm not sure the video is good quality or not. Can you see that?
It's good. It's good.
Good. Okay. The AM and the tibial tunnel is okay. It's okay, right? But look at the right side, the tibial tunnel. This is the tibial, the big, huge. I would say it's more than 14 millimeter, right? It's about 18 to almost 2 centimeters in length, right? So you can see that, wow, it's huge tibial tunnel, right? So how do we manage? Anyone, any expert opinion?
Yeah, we need to do stage surgery for sure, Patrick. The tunnel is that big. This one CT more than 14 is quite big. So we harvest the iliac crest bone graft and put the bone graft into the socket, okay? And wait until the bone completely heal and then come back for the second surgery. That's my idea.
Okay, good. So let's listen to our friend from SLARD, right? So any other suggestions? Anyone will do a one-stage surgery?
Creo que no. Creo que la duda hay.
No, I don't think so. Please go ahead. Yes. So this patient has technical difficulties because of the size and the width of the tunnel. So I think we would all do a double revision. The problem is, first of all, that for the patient to accept that, first of all, because usually it's rejected due to the amount of time that it lasts. And if they had an associated meniscal lesion, that would be the breaking point, because when you have 2 surgeries and you're not stabilizing that knee, it can be an issue. So we tend to use allograft from the femoral head, and so the second surgery would be 6 months later if there has been adequate progress with the graft. The tunnels, especially in these patients, well, these are one of the issues that you have with double bundle. It's very difficult to review it sometimes, to revise it.
Yeah, so indeed nowadays we see more and more this kind of double bundle merging tunnel that demand revision. I think in Asia it's not uncommon, right? Bancha, you would like to agree, right? Yeah. Because
yeah,
we have
a lot of this.
of double bundle 10 years ago, right?
Yeah, double bundle, double trouble, right?
Yeah.
For revision.
So any other
pienso lo mismo.
I think the same. I think you would need to do a double revision. The tibial tunnel is too wide. I also think it's a little bit anterior. So my idea would be to go in and repair that meniscus, clean the tunnels, fill them with graft, and as Rafa says, wait at least 6 months until we do a new reconstruction.
Okay, good.
So the problem is repairing it without stabilizing it. Yes, but you also can't leave it. If you go in to clean the tunnels, you can't do nothing with that meniscus. At least that's what I believe. Yes, no, I agree. You'd have to do something. You'd need some rehabilitation as well. Yes, Rodrigo, I guess you'd look at the crest without a doubt. Dr. Bancha, as you mentioned, that is an alternative, but we also have the alternative of having allograft from the head or from the femoral condyle, and we would have cylinders of bone in the tunnels for consolidation, for combination. We wouldn't scan, we would assume that everything else is consolidated, and with a doubt, I would save the meniscus. The knee will be unstable, but you have to explain that to the patient. This is a young patient. You need to speak to their parents and protect them with a brace. But without a doubt, you would in the first instance, have to save the meniscus. Okay, Patrick, so if you do a meniscal suture in this patient, wouldn't it be interesting to have an extra articular technique in this moment and then wait 6 months for a reconstruction or revision?
No, I didn't do that. But well, thank you very much for all the opinion. I think it's conventionally, we would like to stage it, right? Fix the meniscus, graft it, and then later on, when the graft is good incorporation, we proceed for the second stage. But for this case, let me show what has been done, right? So what has been done is the revision of ACL singles all in one, anatomical ACL reconstruction, just making use just one tunnel with Achilles bulge allograft. This one, you know, when we harvest Achilles allograft, you can cut away the whole calcaneum, right? So you can tailor-make the size of the bone plug, right? Those are very brave, I would say, brave decisions, not conventional, but that save a lot of time, right? And indeed, over the past 5-6 years, I become less and less doing different stages of revision ACL. When we have experience of using bulk allograft, right, especially with Achilles tendon, right, that means that you can easily fill up like a 15 millimeter or 60 millimeter allograft bone defect, right? So this is how it looks like during inside the operation, right? It's a beautiful graft, Achilles, because it's very bulky. You can make it beautiful, right? And then the bone plug lower down can easily fill up the defect, right? So now, well, of course, there are pros and cons. We are gambling on this. You will say that because, you know, we are not sure whether this bulk allograft, the bone part, will heal inside the tibial tunnel. But on the other hand, as you mentioned, sometimes when you pack the graft, the allograft, I mean, APKASS or allograft or bone substitutes inside the bone tunnel, it's not guaranteed that they will heal with 6 months or 9 months or even 1 year. Sometimes the bone quality may not be as good as you expected. So that's why I move towards, if possible, one stage revision ACL. And from our little experience, most of these, one stages with bulk allograft are doing well, right? So for opinions, right? You see now, you see the screw, almost touching the joint, right?
Mm-hmm.
We want to
so
fix
Patrick,
this.
Patrick, how you pass the graft? So you pass the graft from tibia, right?
Yeah. Because you can see the allograft is at the bottom, right? So it just fill up the tibial defect, right? The femur defect is very minimal, so it's easy, just like conventional, right?
On the femoral side also fixed with screw, right, Patrick?
Yes, the femur side is just fixed with screw, right?
And you have 2 tunnels on the femur, you have no problem. You have AM
because
and PL
as you
tunnel.
see the previous video, right? The femur side is indeed quite okay. So we just use the AM tunnel, right? Not using the PL tunnel, right? So you fix the AM tunnel on the femur to the tibial side with the allograft, this like, yeah.
Yo quiero preguntar algo, Rodrigo.
Sí.
I have a question, Rodrigo. I wanted to ask Patrick whether he feels comfortable just using a screw with a soft tissue in the femur or with a soft graft in the femur.
Oh yeah, indeed, that is not something new for us, right? In the old days, we also use screws for fixation or over, the hamstring graft for fixations over the femur side. What you need to do is probably a bigger size screws, right? Of course, you would like to think about all this eccentric fixation and also the osteolysis with the screws. But nowadays, I think for all this like, PEEK material or those biodegradable screw with tricalcium phosphate, it's still quite okay, I would say, yeah.
Patrick, I have a little comment about your screw.
Yeah.
Because I see the screw is in front of the graft, right?
Yeah.
I prefer to put my screw behind the graft. The screw should be posterolateral, so that you push the graft to anteromedial. So you have less impingement and also the graft will not too vertical. Because if you put the screw in front,
yeah, I understand. Yeah. It depends on different situation, Bancha. Can you see that I'm doing some logoplasty for this case because it's a revision case. Because this case, I try many times that I'm worried that there will be anterior impingement. So I try to push the graft to the posterior rather than, as you mentioned, right? Of course, sometimes you are worried about the impingement over the femoral condyle laterally, right? But I think, it depends on the individual. So I'm testing all this. You can see I'm continuously testing and so on, right? Shall we move on? Because this is not the end of the story, right? This is not the end of the story. Okay.
Oh my God.
Okay.
Let's go,
so back
Patrick.
Back to rugby. So back to rugby after about 15 months, right? Re-injured again 3 years later. So this guy with the 2 times ACL reconstruction with allograft, with a bulk allograft, and then this time Natman grade 3, anterior jaw grade 2, pivot shift grade 3. Dow is negative. I just want to show that we have already ruled out those collateral, posterolateral complex, and so on now. Now those are there's indeed quite good incorporation of the pivot allograft, right? But the point is that CT shows that the graft major partial tear of the Achilles tendon allograft again, right? Even though the bone tunnels are okay, but after 3 years, right, he re-injured with a graft tear. And also, there's a medial meniscus posterior complex tear with substance loss. Also, root tear of the lateral meniscus with mild extrusion. As you can see that back here, right? There's the lateral meniscus. The medial side, well, sorry that I just give you one cut, right? But, there's a major substance loss of the posterior part, right? So with this, X-ray. This time I look back into the X-ray. I missed something before.
Yeah.
The posterior slope is 15
slope is
degrees.
too much, right? It's,
I have to admit that in the old days, we always think about ACL is not doing well, meniscus is not doing well, the posterolateral, posteromedial complex may have some problems. But in recent years, I always look back into those repeated failure case on the slope, right? In this cases, they have a 15 degree of slope, right? Now, so gentlemen, right, give you a bit more headache. Now, already 2 times failed ACL reconstructions, fair posterior horn of the medial and lateral meniscus, increased posterior slope. What to do? No operation, afraid of any operation. Patient do not want operation, maybe. Right? Revision.
So how about his symptoms, Patrick? Right now, can he change to swim? Or
no, he want to continue
rugby
rugby,
is too bad, right?
He want to continue rugby, right?
Oh,
so
cannot. I think
those are
we
the
are
options,
not God.
right?
But anyway, I think we can solve his problem to be better, but not back to rugby. I think it's too much, Patrick. I think expectation is quite important for this patient.
Anyway.
Right. So anyway, I think first of all we need to correct the bone first. If they have soft tissue and bone, you need to correct the bone first, because soft tissue operation cannot win, right? Every time. So correct the bone first. So for me, next step is to correct the angle, because this one is 15, it's more than 12, right? So we doing the anterior crossweight osteotomy for him first. That is the first stage. Okay.
Bancha, looking back at the X-ray, there's some varus deformity already, right? You can see that, right? The medial side is a little bit degenerated with a posterior slope, right? So when you do osteotomy, you take into consideration of all this, right?
Okay, we can do 2 things. We can do lateral crossweight osteotomy also, or you can do anterior crossweight osteotomy, but the graft will be like trapezoidal shaped. Okay, you move lateral more than medial. Okay, but so, this way, I think we can use like 3-dimensional CT scan to calculate like PSI for pre-op planning, right? For me.
Maybe our friends from SLARD, any suggestions, right? Bancha suggests an osteotomy, right? To correct the bone morphology first, right? And ask the patient not to go back to rugby, okay? Anyone would like to do, like, for example, revision and extraarticular tenodesis or ALL reconstruction?
¿Puedo operar? Sí.
Sí, Rafa.
Mira, lo primero que hay que hacer con este
The first thing we need to do with this femur is have a long conversation with the patient and explain that he needs to change his patient. We call these people knee abusers, and it's very difficult to continue with them if then they don't understand that rugby cannot continue to be their chosen sport. And I think that's the specific case for osteotomy in our patients with this kind of slope, so 15 with varus. First of all, you have to do a correction, and sometimes that might be enough. You'd have to look at the evolution, but we'd correct the bone. But of course, it's a 3rd revision. Gustavo? Yes, I agree with Rafa. I think we need to reorientate the sports practices of this patient, perform an osteotomy, correct the varus and the tibia, and I would probably fill in the tunnels as well in the same instance, or the tunnels that this patient has, and any bone defects that may be found. Fill the look at the implants, repair the meniscus. And I think you could do extraarticular tenodesis to try to stabilize them in the first surgery, and then the second one you could reconstruct the anterior cruciate ligament. But I think Rafa's comment was very interesting. You have to speak to the patient.
Arturo?
Would you do an osteotomy?
You are muted. Arturo, you are muted.
No tienes el micrófono activado, Arturo.
Perdón.
Sorry about that. Yes, I agree with all of you. I would also do the osteotomy. I would correct the varus and the slope and fill in the tunnels. And I'd like to ask here how you would address the medial meniscus that was already repaired and has ruptured again. You know, they have medial osteoarthritis. So would you keep trying to repair that meniscus?
Very good questions, right? I think there are also apart from whether you do osteotomy, how do you deal with the medial side, right? well, he's young and so on, right? He's still only about 20 something at that stage, right? So option is that you can still go on to repair as much as possible, or it depends on the situation. It's very beyond repairing. Will anyone like to consider meniscus transplant for that cases? In Hong Kong, right, definitely meniscus transplant is not an option simply because we do not have this allograft, right? But I understand that in some places that this is one of the options. But let's go back to this, right? So again, we are doing something a little bit different, right? So that because we want to set everything in one go, and also while correcting the varus deformity and improve the posterior slope, as mentioned by Bancha. Conventionally, people would like to try the closing wedge, right? But on the other hand, what we have performed is an open wedge. But we put the plate and targeting more to the posterior and open up more the posterior side, right? So as to make sure that we can correct the slope, right? And then with concomitant meniscus repair and ACL revision using a BBB graft at this time, right? Now, that's because of time. Let's move on. After this third ACL reconstructions.
So Patrick, how many stages you mentioned?
One stage.
One stage, okay.
One stage. I think
collect the bone and soft tissue.
Correct the bone and do an ACL revision reconstructions because the bone integration is quite okay. So we are not worried about the bone tunnel over the tibial side, right?
Mm-hmm.
So of course there are tricks on, you understand for HTO with ACL revision surgery, you always need to prepare and fix the HTO first so as to allow rooms for ACL reconstructions, right? Usually the ACL reconstructions is more flexible, right? And for this particular case, we aim to put the plate more medial rather than anteromedial, and also opening up the posterior slope more, right? So, well, after that, the medial side knee pain improved, the knee become more stable, we turn back to rugby, not listening to Bancha, okay?
So how many years after that, Patrick?
That was 6 years, altogether 6 years after the first surgery, right?
You mean this time, 1 year later,
this is 2 years later. 1 year after the first surgery, and then 2 years later, another minor injury, right? This time he didn't feel a really big injury, but after that minor injury, he started to think, well, to experience some kind of mild instability on cutting motion. Those are like after 2 years. You can see all these tunnels and all this, right? The point is that, right, this is a physical examinations, right? You can see all the scars, right? And then Nachman's grade 2, pivot shift grade 2, but anterior jaw is quite good, right? Indeed, right? So this is even done under anesthesia. MRI is a minor partial tear of the ACL graft this time, only minor. I think you understand that for this kind of recent surgery, sometimes MRI can't really differentiate some, post-operative changes or even minor tear, right? And there's evidence of previous partial meniscectomy of the medial meniscus posterior horn. That means the posterior horn is almost gone, right? Because of all this surgery. The lateral meniscus is mildly extruded. There's a moderate medial compartment degeneration. Now, gentlemen, 3 times ACL reconstruction with HTO done already, but still with mild laxity. What to do? No surgery? Revision ACL?
No.
Definitely not. LET, ALL? Revision surgery plus LET, ALL? Or adding other procedure like meniscus transplant, because the medial side is getting worse, right?
So what's his problem? Pain or instability this time, Patrick?
Mild instability on pivoting motion, right?
Okay.
Yeah, the medial side knee pain has been improved after. He's roughly at that time is about 25, right?
25. Okay. Yeah. So, any pain on the medial side, Patrick?
Much less. There's mild, but much less than before because of the osteotomy, right?
Right. So I think.
Well, you can see that even with this. Sorry, I'll go back. Right. The anterior jaw and the llama is not like grade 3, right? So more like a little bit of rotational instability, right?
Yeah.
So I'm just asking, will you guys like at this stage, we have done everything except the extraarticular
Lateral
TOD.
side.
Yeah. Will
Okay,
anyone like to add something?
I think so. Because this time the problem is rotational instability. So that is the last thing that we can add for him. So after this, I will stop treating him. Okay.
Okay.
This is the last thing that we can offer the patient. I will do lateral side reconstruction for you. And at this time, I think you should stop rugby. Okay, you can change your sport.
Maybe our
Okay,
friends
lateral side reconstruction, modify Lamere LET for me.
Good.
And for the joint, I
Rafa.
think we can add some visco supplement injection for him. Patrick, this is
Yeah,
another
yeah.
good choice
Just
for
like,
the
bonus,
middle
right?
side. Yeah, visco supplement.
En las últimas radiografías, Rodrigo, en las últimas radiografías que vimos.
In the last x-rays that we saw that there was some arthrosis in the internal jaw. I think I would have spoken to him in the previous surgery and I would have suggested a change of sport.
Yeah.
I think that you have to be a bit more energetic. This patient, conversations are, what is your objective? Is your objective to go back to rugby? Then there's nothing else we can do for them. A meniscus transplant just gives them no possibility to go back to rugby. So there's a difference here between what we can mechanically do. I think that it's basically whatever the patient prefers. If there are processes of instability in daily life, particularly in rotation, and they're going to change sports, then I would the anterolateralplasty. But I think the issue is different here. This patient just, whatever we do to them isn't going to achieve the objective that we want to achieve. Arturo? Yes.
La radiografía se ve un proceso degenerativo importante.
In the X-ray, you can see significant degeneration, as Gustavo said, and nature is wise. I mean, these knees will become partially stable. So maybe in the what I would do is have a very strong conversation with the patient and maybe do something on the lateral part. Now, if they don't have too many intra-articular symptoms, then you could go into the knee and do some cleaning there and maybe do something lateral, or would you rather go to just the lateral part? What do you think, Patrick?
Well, because of time, we only have like 1 minute left, right? Okay. So I think I'll just quickly show you. I listened to all of you, right? So essentially, I just did as minimal as possible, right? So I did the AL reconstructions, right? Well, I didn't do a limit for these cases, right? And then I do an arthroscope and clean up the joint, and that's all, right? So no more meniscus transplant, no more revision surgery, definitely, and give him some visco supplementation, right? So this is my little way of trying to minimize the surgical trauma. Instead of doing a limit, I do an ALL, right? So following the conventional way, the Kennedy's points for the femur side and tibial side. And I use suture anchors in this case, just don't want to create more tunnels over the femur nor the tibia. So it's the best way is suture anchors to fix the ALL using a hamstring graft from the other side, right? So that's how I did it, right? So that's finished, right? Yeah. That's about the cases, right? Okay. So I think this, I just want to bring out the message that we have so many weapons, right, on our side, right? You have osteotomy, you have revision ACL, you have all this, right? But I think we have to analyze all this to pick the right tools, right? Don't throw everything in at one go. And as mentioned throughout our discussion, I think we need to talk to the patients and then explain to him the reality. I think all of you are very correct that for this gentleman, I think it's a new abuser, right? So maybe we as the medical doctors has not been doing the proper way and tried have not been too much convincing him to stop rugby, right? But after all, I think as medical doctors we need to understand all our tools, right, to give him the best tools to help him, right? Yeah, that's my presentation. Thank you.
Muchas gracias, Patrick. Muy interesante. Yo creo que que han dejado muchas...
Thank you, Patrick. This was so interesting. It really gave us lots of lessons, these two cases. I want to thank the presenters. We have finished our time. So I'd like to thank Arturo Almazan, who also prepared a case that we will use for another webinar. And we will continue to do, and doing these presentations with our friends is really comforting for us. It helps us hear your ideas on the other side of the world where things are completely different. With regards to rugby, we obviously coincide because we do play a lot of rugby in Latin America, so we do share that sport, especially in Chile and Argentina and Uruguay, where they're quite strong with rugby. Before we close the webinar, I'd like to thank all the presenters who were here, all the participants who left their private activities aside. And I didn't mention before that in November, we will open the contest for the fellows of SLARD towards the Pacific area, which is an incredible fellowship. So I recommend that you register, put up your CVs on the webpage, and we can select people. The trip will be in June 2023. So registration is open for all applicants for that traveling fellow. Without further ado, I'll let you go. And Pacific Asia can go and dine, and Latin Americans are starting their weekend now. So we hope that you have a good time with your families and have some rest. Thank you once again. Thank you to all the presenters, Rafa, Patrick, Bancha, Arturo, Gustavo, etc. Have a great day. Thank you to you all.
Thank you. Have a nice weekend.
Thank you very much.
Thank you. Bye-bye. Thank you all our SLARD friends. Thank you. Bye-bye. Thank you, Bancha.